How do you determine if a PBM is active or passive?
We define an active PBM as one that is participating very closely with a specialty pharmacy in relaying good benchmark data on performance. And the performance areas we look at are clinical performance, financial performance, and service metrics. If you think in terms of clinical, you're really talking about adherence rates, refill rates, physician intervention calls, and then accuracy of the fills. When we talk about areas of financial, we're really looking at how actively involved are the PBMs and the specialty pharmacies in taking advantage of copay assistance programs. This is an area that has great value to the employer and to the employees, and you really want to know how well they're participating with those programs. The third area of service metrics are really built around the issue of every specialty pharmacy has a call center at its front. If we think about call center metrics, we're really talking about hold rates, time to answer, dropped calls, program or problem resolution timeframes. Again, you're really looking at service metrics. Additionally, we really want to know about delivery timelines. How long does it take to get a clean script to the patient? And then most important to me is missed delivery dates. Are we talking about problems with the logistics? Are we talking about difficult patients? Where are we at with delivery timelines? That would define an active. By nature, if you're not getting this information, you need to ask yourself, are you in a passive relationship?
In your presentation, you compared and contrasted couponing versus copayments. Why should an employer care?
Well, there are two issues. We first need to understand that they're both strategies deployed by pharmaceutical manufacturers to impact utilization. So if we look at couponing, we know that it has an effect on the cost to the employer. It is a strategy that is meant to inoculate the patient to the copay differentials from preferred brands. If you look at the recent PCMA Commission study by the Vicente Group, you'll see that there's a prediction of significant costs over the next decade as a result of the couponing strategy, as opposed to a copayment strategy where pharmaceutical manufacturers are using copayments to allow affordability of the more expensive specialty drugs. So here we have a situation where coupons could be perceived as not necessarily good for an employer because they're driving up the use of brands or non-preferred products. In the copayment world, we're really looking at a program where manufacturers have stepped up to say, these drugs are expensive, employers are putting large co-insurances, large copayments in, and we have a way to try to mitigate that and make it more affordable for the patients. The key here is that we understand there's plenty of research to demonstrate that as copays go up, co-insurance rates go up, you have less adherence rates. So it's really meant to really address both those issues. That benefits the employer directly as opposed to costing the employer.